Good evening, everyone. My name is Jen Nolan and I'd like to welcome you to the final webinar in our 2016 Musculoskeletal Health webinar series and the sixth webinar as Move, Muscle, Bone and Joint Health, the new dynamic voice of arthritis and osteoporosis Victoria. Due to funding from the Victorian Government, we are also delighted to be providing this webinar on the management of persistent pain at no cost to Victorian primary and community health professionals. I'd also like to extend a warm welcome to health professionals who are tuning in from other states of Australia. I'd also like to take this opportunity to inform you of the series of webinars that we have scheduled in the first half of 2017. We will be covering issues such as falls prevention, management of low back pain, common foot problems, and pain management in people with inflammatory forms of arthritis. Details regarding these webinars will be on our website in the coming days and will also be sent to you. Before introducing our presenter for this evening, however, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please feel free to type a message in the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions at the completion of her presentation, you can actually type questions for her at any time. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Summer Time. Any unanswered questions will also be answered offline and provided to you in the days following this screening tonight. I'd also be very grateful if participants could take a moment at the end of the webinar to complete the exit survey. So to our presenter for this evening, Associate Professor Carolyn Arnold is a pain medicine and rehabilitation medicine physician who leads a multidisciplinary chronic pain program at Caulfield Hospital in Melbourne. She is a strong advocate for optimising chronic pain. A former president of the Australian Pain Society and former board member of the Australian Faculty of Pain Medicine, she enjoys teaching, training, clinical research and patient care. Without further ado, I'll hand proceedings over to Carolyn. Thanks very much, Carolyn.
Okay, thank you everybody and welcome. I'm very happy to be giving this talk, and I can see that the schedule for next year is going to offer more concepts on some of the themes that I'll be discussing tonight. So I guess one of the things I thought I'd put up first is actually this message that I heard at a recent conference, and I put it out there. It is out there, but it's really to emphasise some of the directions in which we're going. So the strong message was that chronic pain is a biopsychosocial problem. So we're not just looking at it as a tissue-based issue. And because of that, obviously we need to include those biopsychosocial aspects in our assessment and treatment. Sadly, one of the other messages is that we're finding increasingly that medications have limited effect. Many patients don't get response to medications, the effect is only partial, and so we have to develop other ways of helping people to live a better quality of life if they have pain. And again, some of the particular interventional treatments, which are tending to be tissue-based, are not always going to be applicable for many of the conditions that we commonly see. And so I guess as a vehicle for addressing biopsychosocial problems, interdisciplinary rehabilitation seems to have more effective and durable results. And I guess one of the big messages is that it with some knowledge and insight can be managed in primary care for the majority of patients. You know, the high tertiary hospital interdisciplinary rehabilitation programs are for specialised knowledge resources and more difficult patients, but it's more important for us to be able to manage these things in primary care with people in the community with the right skill set. So I was encouraged to put in a case study, and I put it in at the beginning, and we'll talk about it at the end, but this is just to set the scene, I guess. And this is about a patient, Beth, who's 49 years old, and she's presenting in your practice, whether it be medical or physical or other sort of community-based, with bilateral shoulder and middle back pain, which has been present for quite a long time. She tells you that it was initially intermittent, but it's become persistent for 6 months. She's aware that when she does her clerical job, that it aggravates her pain, and she's been getting some headaches as the pain has worsened. So far, she's been taking Panadine and Nurofen, which she's been buying over the counter. And she did attend a chiropractor and found that the physical therapy treatment that was prescribed aggravated her symptoms. So she's now coming into a different context to see what help we can give for her pain. Now, this is a very common scenario, and it's just to set the scene of what we might be seeing in our practices. So if we're going to talk about chronic pain, obviously we need to have an idea about the definition, and many of you will probably have already seen this definition, that it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. There's a lot of criticisms of this definition. I guess unpleasant sensory doesn't often evoke the severely intruding pain that people experience, so it's possibly a bit weak. And I guess it does, in good sense, emphasise the emotional experience, that it actually harks back to memory and previous experience, and that sometimes the pain can be just as severe even without actual current tissue damage. And that's increasingly explained by what we understand as neuroplasticity of the nervous system. So when we talk about chronic pain, it's very common, and it typically is recurrent or long-lasting pain present for 3 to 6 months. And it's so common that 20% of the adult population at any time are experiencing chronic pain. And in older patients, it's over 30% of 65-year-olds. So we have this impression that, 1 in 5 people or 1 in 3 people in the community are there with chronic pain, and yet not all of these people are seeking our treatment. So why is that? And I think that this work from von Korff, which is actually quite old, is quite important, because what we really know is that there's a lot of people in the community who have pain which meets the definition of chronic pain, but they are functional. And so that it makes us seem that more people are sort of disabled with chronic pain than actually are. In reality, it's about 25% of that 20% or 30% who are actually severely impacted by their pain. And this was described as grade 3 and 4 sort of chronic pain, where there's high disability and moderately limiting function, and high disability, which is severely limiting. And these are the people on whom the impact of chronic pain is very significant, and who are usually the sort of people we see in healthcare who are not functioning. So I think that's helpful to have an idea of what the grade is. And also the other thing we can do is we can look to the copers and see how they manage the pain, to teach us how to help other patients who are struggling a bit more. So one of the important things, obviously, is that when people have chronic pain, it usually began somewhere. And it actually started off as maybe acute pain or acute intermittent pain, and somehow it evolves into enduring symptoms. So I guess one of the important messages, as we already know that acute pain is not the same as chronic pain. So what we have to be aware of is when the transition is occurring, when the acute pain doesn't resolve, when the musculoskeletal pain starts off and doesn't recover as we expect, because that's the time when we have to change our paradigm for treatment. We know that when there's nerve injury, which can cause neuropathic pain, that there's a greater risk of this pain being severe and going into chronic pain. And also we know that there are contextual things, and for example, case injury, we're aware that compensation, although it's helpful in some situations, it adds a lot of complex psychosocial factors into the mix, but because of the impact of it on work, and because compensation sometimes isn't always fully supportive. So what we're increasingly aware of is that those issues, other than the actual injury, the disease or the degenerative process, are really relevant in the development and maintenance of chronic pain. And you may have been in the past exposed to the idea of yellow flags. A very old concept that's probably been around for 25 years. But I think it's still a very good, simple concept to have about looking for the yellow flags. And I guess the other one that we're increasingly aware of is that if someone's got escalating analgesic requirement, obviously the pain's not improving, and the actual analgesic usage can become a big issue in itself. And we'll talk more about that. So I guess this little graph is just to try and explain what normally happens with an injury. And I guess with normal injury, what we have is a pain level that starts from being well and then goes right up, and then usually quickly, within days to weeks, it resolves and the pain resolves. But in the percentage of people it doesn't cover in, it actually sort of continues on. And what we're increasingly understanding is that when the pain persists, it's more associated with the nervous system's response to the initial injury than in the actual primary tissue injury. And these are hard concepts to understand, but I think they're very important. And this is, and again, I'm harking back to some very old work, which is at least 20 years old, of orthopaedic surgeon in Glasgow, Gordon Waddell. And this is a figure about percentage of people who return to work after back pain. So when the first back pain starts, obviously 100% of people are off work. But within 40 days, you've only got about 10% of people who haven't returned to work. So with back injury, most people get better. But what we have is a small group of people who end up having prolonged and severe pain. And that's the group that we really, obviously we want to avoid the fall into the chronicity by acting early in here, probably starting to screen really early to try and reduce the number that go on to have chronic pain, which has a lot of challenges. Whenever you talk about back pain or any other musculoskeletal pain, obviously there's always a fear that we will miss something that is really seriously threatening to someone's health. And I've just put this up once. I won't talk about it a lot, but I think obviously early on screening for red flags that might suggest that conservative so-called management is, you know, to screen off the red flags. And I've put this list here, and obviously, you know, if there's a suspicion of trauma or minor trauma in an osteoporotic patient, I think one of the traps that occasionally will trap us all is that someone presenting with new back pain who has a past history of cancer treatment needs to be looked at a bit more closely, because it could be either a side effect of treatment. I did have a patient who'd had an osteosarcoma who developed renal cancer, which presented as back pain. So if there's those sort of histories in the background, it's probably worth investigating a bit further. And then there's other constitutional symptoms or atypical presentation of pain. The other one is IV drug use. Unfortunately, it could suggest the risk of infection. And obviously, it's more easy usually to find when there's significant neurological deficit, but be aware of these sort of problems. And important part of the screening process is your first assessment, including spending a little bit of time to do a thorough physical assessment as a basis. So we'll move on from red flags. But I've already said one of my key points, which is you need to take a bit of time to evaluate the patient. And if you're in a busy practice and you haven't got limited time, that's all right. You can do it over a couple of visits as long as you have a plan to do these things. But what you want to really look for is psychological distress. And also to find out what the person's temperament is towards self-management. You know, if you're going to give guidance, are they going to take it on and do some activities themselves to help with the pain? Another important question is about whether the medications are being effective or not and leading to an improvement in function. So increasingly, we don't just measure pain improvement on pain scores, because sometimes the pain score change is modest, but it's whether they're able to improve the function that's much more important. Are there any indicators of medicine risk? What about physical activity? You know, is someone reducing their activity? Are they not able to continue walking? What physical factors seem to make the pain worse? Is the sleep affected? Nutrition is increasingly important, and I'll talk a bit more later about obesity, but good nutrition seems to be very important in general health, constitutional health, particularly with musculoskeletal pain. And I guess in the first instance, having seen the patient, it's nice to make a little treatment plan, which you might formalise later on, but actually I'm going to have these 5 steps, and next review we're going to do this, and start to lay it out for the patient as well. You know, I want you to come back in a week and see, all that sort of thing. So start thinking about the end early on. So what are some of these other yellow flag factors? So gender is a risk factor. There is a lot more chronic pain in women in a lot of the diseases we see, so that's important. Psychosocial factors indicative of pain chronicity include psychosocial stressors and early life stressors. Now, this is almost going back to developmental history, and that's something that's increasingly a rich source of screening. The other thing is to find out what the person's beliefs are, like negative beliefs. If the person has an understanding that if they have a certain musculoskeletal pain that it will be harmful or it would lead to disability. And this is about stories and people's life stories and the people in their life or the people who are advising them, or even the inadvertent comment that somebody has made. Sometimes simple comments can really quickly lead to a strong negative belief. And with this can be tied up this thing that we'll talk more about, which is fear avoidance behaviour, which is where the person very quickly learns that if they do something that it causes pain, and they very quickly stop doing physical things because they're fearful that the pain will be worse and they won't manage. And this leads to that downward spiral with reduced activity levels. The other thing that's quite interesting is that many patients have the belief, particularly with medical treatment now, that it's something that is done to them. rather than something they're actively involved in. And I think we have to increasingly look to the concept of the patient being an active participant in treatment, and also recognising that, that we're not omnipotent, we can't cure everything. There's a lot of press and media that's talking about fabulous things, but it's still about self-management. We'll talk a bit more about catastrophizing. You might have seen this a lot. Catastrophizing is seeing the worst. It's the negative, pessimistic view that everything will go badly. And that's one of the challenging areas that we try and address in our cognitive behavioural therapy, is to rewrite the catastrophic scripts. Catastrophizing is strongly associated in research with poor outcomes for post-surgical pain, musculoskeletal pain. The other thing is mood and depression, low morale, social withdrawal. I think we have to be very alert to this kind of factors, because they in themselves can contribute to a downward spiral, and we need to address them early and be aware of them if we need to garner some services to address these things. And obviously social and financial problems, social and financial disadvantage are also risk factors. And I've just again put that compensation in the thing that we mentioned before. Now this is a very recent pictogram really that was from Pain, which is a sort of international journal. And this is from Jerry McFarland, who's actually an epidemiologist. And what he's tried to summarise is some of the biological and developmental factors that are associated with chronic pain. So the first thing is childhood. The context of childhood is very important. Have there been significant others in the family who've had chronic illness or chronic conditions? Whether there's been a stable family that's nurtured children to grow well or not, whether there's been abuse or neglect of children. We also know that children that are exposed to painful procedures as neonates, such as in intensive care or early surgery, have increasingly sensitive nervous systems, and there's a greater risk of them developing chronic pain in adulthood. We know that there are some biological mediators of pain. Now, the last thing I want is for you to go home thinking that genetics is the answer. It's not, but it is a contributor. And there are some people whose genetic makeup, when it's added with environmental things, means they're at greater risk of pain. And there are some people whose genetic makeup is very resilient and resistive. So it is what it is. It's a factor, but it's not the dominant factor. But nonetheless, we're becoming increasingly aware. In the future, we'll see personalised medicine and even different drug prescriptions according to genetic makeup and metabolism. Stress response. People who've been exposed to a lot of stress and have a heightened stress response are going to be at greater risk. And this is the sort of factor of chronic pain in adulthood. So we've got the risk markers, altered mood, poor sleep, all the stuff we went through. And we've talked about the predictors. So I think that's quite a nice little picture if you like pictures rather than written. So I want to just emphasise that chronic pain is about vulnerability and resilience. Genetic factors and environmental factors, and I say S, factors, because the factors are not in isolation. I'm trying to get the dot here. Anyway, if you look at the genetic factors and the environmental factors, they're multiple factors. They're not just single ones. There's a whole lot of different polymorphisms in drug metabolism and environmental factors. It's not a single one. It's the multiple overlapping ones that are relevant. And so just my little cartoon for you to help understand catastrophizing. This is the despondent, helpless, catastrophic thinking. I'll never get better. I can't do what I used to. I'm useless. They should cure me. It's external locus of control. That's, passive treatment. I can't stand it. Why do I hurt? Am I imagining it because people don't always see it on an X-ray? No one believes me. And this leads to this cyclical problem of fear, depression, frustration, and fury. And we have to be aware of this because we need to tap into it therapeutically. And beliefs often drive behaviour. And there's an example of what we just talked about. So we've got an activating event, for example, a back strain at work. The belief is that the work is too heavy and that I should bed rest until the pain goes away. And the consequences of this belief is that the person quickly becomes physically deconditioned, the pain continues, they can't work, and then they start the downward spiral. So part of what we need to do is we need to address beliefs, and that's really important behaviour. And the other thing I mentioned before is the indicators of medication risk. Now, I'm not going to talk about medication much, but obviously the conditions with opioid dependence are increasingly complicating chronic pain management. And our current concern is that we've actually probably overprescribed opioids, and it's caused long-term problems. And so from a safety point of view, medication risk over 40 milligrams of daily oral morphine equivalent is of concern. The 90 days I'll talk about in a minute. Opioid risk tool I'll show you over the next slide. And I think the other thing we need to be aware of is there are side effects from over-the-counter medication. So you may have seen some of the press in the last day about Nurofen with codeine preparations where people have severe gastrointestinal and renal disease because they're addicted to the codeine, but they're taking excessive doses of paracetamol or ibuprofen or an anti-inflammatory with that medication. So there is a risk of exposure to addictive medications and addiction developing in people with pain. And what I want you to really remember is that if someone's taking opioids at 90 days after the onset of chronic pain, 80% of those will continue to take them long term. So it's a big problem. And just quickly, and the slides will come to you. I think I saw a question flashing past that someone wants to see the slides. You'll definitely get them. But this is just an opioid dose equivalence because many people are unaware. For example, the 25 microgram per hour fentanyl patch, Duragesic patch, is equivalent to 100 milligrams of daily oral morphine. And a lot of people don't really realise. They think it's just a little dose, and it's not. So some of these drugs are much more potent than are realised. And converting back to the morphine and deciding whether they're under 40 or getting over 100, which is very dangerous. And this is just the prediction tool for opioid risk prediction. And this is an old thing that was developed by Lynn Webster in the States. And it's certainly quick to do. You can do it in your practice, just quickly ticking the boxes. But these are the sort of factors that seem to be risk. So alcohol, in different illegal drug use, even past illegal drug use you need to know about, prescription drugs, personal history, age, history of pre-adolescent sexual abuse does seem to be a significant factor for women. And I've seen some men in that's occurred as well, unfortunately. So psychological disease. So different psychological things need to be considered also for treatment in the treatment plan. And this way you can score your risk that these things will put a high risk if opioids are not dealt with properly or aberrant behaviour may occur. So that we often have adverse selection of patients in that people who failed other treatments who already have a high risk profile are more likely to be placed on opioids, and this is a big problem. 20 years ago we thought that opioids would be safe in chronic non-malignant pain, but now what we're seeing is addiction in up to 20% of people who are prescribed these and don't get off them quickly. And the high risk is with high doses. There's lots of things like, well, addiction is one, but there's also sedation, sleep apnea is aggravated by high-dose opioids, osteoporosis, there's metabolic changes with opioids that increase endocrine dysfunction for the gonadotrophins, which also includes the risk for osteoporosis, there's dental health. So there's a lot of things that we have concern about. And also more recently, the Americans are sort of telling us that the long-acting opiates are more likely to produce tolerance and that dose escalation can happen quickly. And these are all things we wish to avoid. So just getting back to your assessment of our patient, I'm a big fan of physical examination. I think you can learn a lot from examining patients, and I think it's a different transaction in your relationship with a patient. It shows you're taking them seriously. You can do examination, you can find out a lot of information, but you can also observe a lot of behaviours. So it's helpful to know what the reduced range of movement is, whether there's consistency, whether there is a neurological deficit or not, where there's tenderness, is it localised or widespread. The behaviour is very interesting in how people move or don't move. And consistency if you're examining on more than one occasion. Well, I guess what we're coming to is the fact that self-management is fundamental to the approaches we use to chronic pain, and that really the medications are only just an adjuvant and they have a time-limited role. So they might facilitate the recovery into self-management, and that's often the way we use things. We might try and get things a bit under control, we might treat the depression, but the goal is to restore function, and these are just vehicles in the short term to use with that goal in mind. And I guess the other thing we're trying to do is to move to bring the patient on a journey, focusing towards active participation, and it's not dissimilar to what we were aiming for in the management of other specific forms of arthritis or diabetes or high blood pressure, where lifestyle factors are really important. And I think it's important to sort of have the concept that a primary carer could be a coach, and promoting sort of adaptability and resilience and lifestyle approach. And I don't know that there's specifically psychological people treating pain who are going to be talking in the future, but their skills or the opportunity to train in some of these psychological matters is very important if you're going to manage comfortably in primary care. Okay, so more specifically with the goals, we want to improve quality of life, and that's mood and function. We want to actually educate the patient and give them the understanding and knowledge, if at all possible. And health literacy is quite important, and I've got some ideas about education in going on. But the more the person can understand their experience in a meaningful way from a rehabilitative perspective, the better. Strengthen any coping, really reinforce when they are managing and coping well. And physical activity, I can't emphasise it enough. And I've been having some discussions with Jen, who's our moderator tonight, about the shift of the Arthritis Foundation to move. And I think increasingly maintaining physical activity and avoiding functional decline and losing weight if people are overweight, these are really important long-term things to manage pain. And I guess on the other hand, we want to actually avoid the traps, the depression, the drug dependence, the unemployment, the sleep disturbance, overuse of inappropriate or expensive therapies or invasive therapies with risks. And I think there's a whole big industry out there of people wanting to sell stuff that's actually not very strongly evidence-based in the community. And the risk is patients can spend a lot of money without making a lot of progress. And that's also something to be wary of. So I've put this slide up here that I got from somewhere in my preparation. I can't even remember where this one came from, but I guess this was my tilting my hat to the medication. That's as much as I'm going to say about medication, really, is what I've already said. So with musculoskeletal conditions, we use simple drugs as long as they're safe for kidney and gastrointestinal function. Nerve conditions, we use the more complex drugs such as the gabapentinoids, the antidepressants, including the tricyclics and duloxetine, and we try and keep the opioids down. But we need to also address the physical disability and the mood disturbance, and this is much more where we use the behavioural approaches or a multidisciplinary approach. So I guess one of the things in primary care is to work out whether you feel that it's appropriate to manage it there and if that's going to be appropriate or whether you need to refer. I've already said about the multidisciplinary approach, addressing understanding and challenging inappropriate beliefs. So the discussion or the counselling can be about, finding out what the beliefs are and trying to have a discussion about why that could be changed. And reward and acknowledge progress wherever there's been some progress. And some of that progress is best monitored not by asking about the pain when you're reviewing a patient, but asking about their function. They've sort of set out to do something to increase a little bit of activity, to return to work, to participate in something. That's what you need to reward with your attention and acknowledge, not rewarding pain and negative things. So one of the big challenges is actually getting people moving again. And I was really pleased to see that Peter O'Sullivan's speaking on the 27th of April, because he's very good at speaking about this, and many of the physios who are here tonight may have heard him speak. But I think we really have to address not just prescribing exercise, but we need to overcome the fears of that exercise will hurt. And in fact, for many patients with chronic pain, activity does increase pain. So we have to help them to get a way to move forward. And thirdly, there are some patients who are actually overdoers. And overdoers are also at risk because they want to do too much, and that means they get more pain and then they collapse. So sometimes there are some patients we need to slow down a bit to get them to be more manageable with their pain. So you've got to work it out in your own assessment, which sort of patient you've got. And one of the things that we talk about all the time in chronic pain management is pacing. You've probably all seen it. And I think the other thing that I find easy to understand is this thing about the boom-bust cycle. So the boom-bust is obviously collapsing and not being able to do anything for too long. And the problem with the bust is that sometimes people never get back to a functional level. They keep on going down. And certainly that's what we're trying to explain with this graph here. There's a good day which is followed by a bad day, which is followed by a not quite so good day. And overall your activity level is just going down and down and down. So what we want to do is actually very gradually reverse this kind of cycle. So when people go bust, they actually need to rest for too long to recover, and they can risk a pain flare. So part of the treatment, it's a bit like an asthma plan. It's to avoid an exacerbation, but also how to come back up if you do have an exacerbation, to recognise that it will be finite and it will improve with the right management. So I guess what we're trying to do is to keep a person active but in a manageable pain level, in the green level. And in the yellow level, it's just going a bit too far. And red is really quite dangerous because it may lead to reduced function. And this is the stuff that we want to talk about when we're working. And in fact, there's a very good pain physician called Stephanie Davies in Western Australia who's got some really nice things on her website. And one of the things that she talks about is smart goal setting for physical activity. So she talks about strategic, specific, measurable, attainable, results-oriented and time-bound, and it's particularly for physical activity. So she uses a 10% rule, which is a base timed daily activity. So say the goal is to walk for 30 minutes. So you start with a lot less. So 3 minutes isn't very much. So she's actually often will go for 10 minutes. So they commit to the selected activity every day for a week, and they increase the time by 10% for the next week and so on. So it's very, very slow and gradual. This is part of the education, because a lot of people who've been very active think that's a bit sort of sooky to only do it for 10 minutes. But what you're aiming to do is to very gradually activate them. Now, some of you may have had contact with spinal surgeons who've used walking in this way for a long time very effectively. And I've often thought you shouldn't need to have a spinal operation in order to go on a graduated walking program. And the other thing is small bits often. So split the task up to twice a day. And the other thing is small bits often. So split the task up to twice a day. Or if you've got a few things to do, just do 10 minutes and then change, or have a little rest and then do another 10 minutes. So this example here is gardening for 10 minutes, walking to the letterbox for 10 minutes, tidying the kitchen for 10 minutes, having a sit for a little while, then doing the garden. And this is all about changing posture and balance and taking a bit of time to listen to your body. So non-paced activities are really ones where they are dependent on pain. So if someone's got a lot of pain, then they won't move at all. And you have to overcome that and just say aiming slowly to build increased activity within that green section that we just saw before. And for the overdoers, one of the great risks is that they'll increasingly rely on medication in order to overdo. And so it's a bit risky if you're overdoing all the time and then taking rescuing medication. It's sort of getting in the wrong direction. And I think the other thing about overdoers is they're often quite complex, and sometimes when you probe, you will find that an overdoer is going to be avoiding other factors. They may be overdoing to avoid some other stress or something going on in their personal life. It can be a maladaptive coping strategy, and sometimes it takes a bit of work on the psychological sort of side to really look at this pattern of behaviour to get insight in order to address it. You can't just ask them to slow down unless you address the necessary factors. It's like saying if you do this behaviour, you'll get better. But if there's an underlying driving force, you've got to address that. So I'm a big fan of lifestyle factors because there's a lot of maladaptive things that are coming on. And inactivity is obviously a great concern, and particularly into ageing, but even in younger people with chronic pain, inactivity leads to a lot of poor health. And weight gain is one of those. Also, the medication side effects that can be really quite adverse. They can cause patterns of poor activities, sleepiness during the day, not necessarily sleeping at night, not mentally sharp, just not caring as much about fixing things. Depressed mood is a common problem. And all of these lifestyle factors and withdrawal from activity can lead to social disconnection, which in itself can worsen these factors. So we have to be aware about these connecting factors. One of the things that I've been really interested in lately is some of the new research about osteoarthritis that Flavia Cicottini from Monash and Alfred Health has been talking about quite a bit. Because osteoarthritis is actually a huge challenge for us in the future because of the ageing population. And we can see already that it's going to be a big cause of chronic pain and disability. And the common sites for osteoarthritis are the knees, hips and thumbs. And I've put thumbs in there to remind you that we always tend to think of osteoarthritis as a disease of worn down joints from weight, but thumbs do not get subjected to weight, but they do get subjected to arthritis. So it's a growing health burden, And one of the things we really have to do is prevent. We have to reduce progression. We have to manage people for longer before they need joint replacement, and we have to educate them about management. So I've just got this little cartoon here to remind us about BMI. So weight in itself isn't always a good indicator of the amount of obese tissue, adipose tissue that we're carrying. There are some people with a certain body type or a very muscular build who can have a high BMI who are not suffering with excess adipose tissue. And there are some people who would even fall within BMI ranges who actually still have high percentage fat. So I think we need to probably assess a bit more about fat. And Flavia's message is really well enunciated in this MJA article from February 2016. It's well worth reading. It's only a page and a half. But she really talks about the fact that body fat is not an inert structure. And the analogy that she gives in her teaching is that, you know, you're much better to be holding a lump of concrete. 20 kilograms of concrete is probably much better for your joints than 20 kilograms of body fat, because the body fat is immunologically active. It causes inflammation and it stirs things up. And increasingly we're recognising that the combination of inflammation plus weight is more damaging to joints, to the substance of bones under the cartilage, than just the weight in itself, and that we really need to address obesity if we're going to get on top of osteoarthritis. So I would certainly commend this kind of thinking to you, to just change your sort of thinking a little bit about it, because I think we're better with weight. You can buy these Tanita scales. They're not ideal, but they certainly have been used in some of the studies, which will estimate body fat if you enter data about age, height, and measure weight. And that could be something that you could do as a goal setting for nutritional approaches to reducing weight. And I think we need to spend that little bit of time about highlighting that with our patients, the way we're doing with smoking. In the research, they've actually used DEXA scans, which obviously give more information, but that's more of a research tool than something that we'd normally use. So we're getting around to this idea of educating patients, and I don't know whether you can see, but I was sitting here at this desk of Jen's waiting to come in, and this is a new book, the latest book by Lorimer Mosley and David Butler about protectometer, and I'd like to plug that too, because it's a workbook for patients to help them understand pain. But preceding the protectometer book is certainly David Butler's work on Explain Pain. It's a very good book. It's a good book for health professionals to read in order to get the language to talk to your patients, but it's also for patients who are reading, and not every patient wants to read. It can help them to explain why it is that they can't see their pain on an X-ray, why the brain plasticity affects the pain, and make sense of their experience. And the other one is sort of slightly different, with Lorimer's sort of using painful yarns as metaphors for understanding pain, and that's a bit different and quite a bit of fun. So I think they're both worth knowing about and perhaps reading yourself and maybe recommending to your patients. The next thing that I wanted to speak about was the limitations of radiology, and I think, you know, many patients are disappointed that they can't always get an answer on radiology, or the other thing is the problem with radiology, which seems to overemphasise that there's structural damage which is unavoidable and it's bad. So the thing we have to remember is that radiology doesn't tell us about pain, and that the structural changes are not proportional to pain. And there's been quite a lot of studies done in osteoarthritis where the actual pain scores are not reflected only by the Kellgren score of the arthritic deterioration. There are other factors measuring some of the things that we've just talked about, which can also influence the pain. And the other thing is that there's a lot of normal age-related changes that get reported as pathology, and the language of the reports is actually quite catastrophic, and it's quite damaging, and I think it's a big problem, and we need to address it. And one of the things to do is to really try and avoid over-investigation where it's not needed. You have to be aware that patients are exposed to radiation risk, and that many times that radiology won't change the management of uncomplicated spinal pain. So I think, you know, in the same way we've had to learn to not prescribe antibiotics for every sore throat, I think we have to be careful not to use X-rays for every musculoskeletal pain, or even fancy or more expensive scan. History taking and physical examination is important too. And this is just a very interesting table out of Brinji's radiology journal, and I just wanted to highlight it to you because it really shows that actual damage kind of things are very common in people free of pain. And I mean, you'll get these slides on PDF and you could use it for your patients, but I just want to point out that at 40, 68% of people will have facet degeneration in their spine. And at 50, 32% will have facet degeneration. And what we also know is that this research was actually done on people who did not have pain, who had scans for whatever reason, maybe for something else, and they found these things. So this is actually a normal population that's pain-free that has degenerative change. So there's a very poor specificity between radio imaging results and pain. And again, just to remind you that X-rays are for red flag concerns. Radiology imaging, CT is for these. Now this is a very big slide with a lot of information. I didn't want to go to town on it for you, but I just wanted to highlight a little bit about cognitive behavioural therapy, which is something that can be adapted into a physical therapy program, but it's really about educating people about how fear can impact on the experience of pain. And there's a lot of research studies, quite funny things, interesting things that have been done, you know, that when you experience pain, if you're given a red light at the same time, you'll experience the pain worse than if you're exposed to a blue light. There was a really interesting one that has been talked about recently, which was called the creaky door study, whereby if someone was in an MRI scanner and they're given an image of someone in pain and the sound of a creaky door is made at the same time, they report, or when they're sort of given a pain stimulus, that they will feel more pain if they hear sound of creaking because it creates this image. So we have to be really aware that there's a lot of environmental things that will wind up the pain. And what we need to break it down is actually try and understand the fears and use some exposure and stress anxiety so that people learn over time that they can move a bit and that it won't necessarily lead to pain like they've learned previously, and to have confidence that they're not damaging, you know, that the pain does not equal damage. And in fact, you know, a lot of these musculoskeletal conditions, what we know is actually that movement is the key to improving the pain. And so I think this combination of that, either with psychology input or with physical therapy, where people are wise to this, using a gradual exposure and reward, very I've just got, I can't help, I'm seeing some of the questions coming through, and someone's just mentioned that acceptance and commitment therapy can be useful for catastrophizers. So it's not my role to go into detail, but there's a lot of different psychological. ACT is certainly one of those ones that we're using now, and it's very useful, and it's a good suggestion. So I'm not saying which specific type of psychological therapy, but these ones that address fears and catastrophizing and help acceptance of the pain, all of these things are useful. And education is the role, and learning to have the language to do the education and the resources. And you can't ignore the fear because it's going to be a big driving factor, and it's like the elephant in the room if you don't tend to it. So coming back to our beginning, is the patient actively managed in self-management, maintaining normal activities? Are they using some non-drug ways of calming? Are they taking a problem-solving approach? Are they fully engaged, partially engaged, or not engaged? Because this is going to have a big factor. A fully engaged person is going to make good progress, but if someone's not engaged, it's obviously not working well. You might have to change. So I've put up some, as well as the books, I've got some nice resources here for you. You might want to make a plan that includes a psychologist. And again, you've got to select the right psychologist. If someone who can manage chronic pain has got some good language. You don't just want supportive there sort of counselling. We want active cognitive therapy, such as these things. It's really important to do that. And there's a very good health plan that's available through the Agency of Clinical Innovation in New South Wales, who's got a lot of resources now for chronic pain. So all you have to look up is Agency for Clinical Innovation, Chronic Pain, and there's some good patient little YouTube videos that are very short and very to the point and very useful for patient resource. Another course that I found, which I've had a few patients who've used, is actually Macquarie University on their psychology courses have actually got a pain course online, and it's very interesting and quite good according to the patients who've liked it, but it does tell you all along from the beginning, this will involve work. You can't just, it's not passive, you have to work if you're going to get the benefit, but apparently it's a very good way of learning about some of these concepts we've been talking about tonight, so I'd also recommend that. So obviously there are some times when your patients are needing to be referred elsewhere. So these are just some of the diagnoses, such as complex regional pain syndrome, neuropathic pain not responding to treatment, pain that's persisting and seems too difficult, high psychological distress, or healthcare utilisation increasing or morphine. These are all the pointers of where you might need help, whether it be with a multidisciplinary pain clinic or through a sort of multifaceted approach in your own setting. So this is again the pain management network, and this is actually one for primary care. It's slightly different messages from today, but I'd certainly recommend it. It's very clear and it's got lots of step-out boxes with details. I've taken a couple of the slides you'll see from today from this network. And it's a very good resource, so I'd recommend it to all of you if you want to read a bit more or get some more resources. It's all beautifully done online. So we finalise our talk by coming back to our case study in Beth. Just to remind you with the bilateral shoulder and middle back pain. So when you explore Beth's case further, she's very fearful that she's got some shoulder pathology which is upsetting her thoracic spine, and she's actually getting very tired and her sleep is disturbed. But when you find her, you actually find that she's got some mildly restricted neck rotation on one side, but she's got no neurology in her upper limbs. She's actually quite muscular. She's got a full range of shoulder movement, spine straight, but she's actually quite diffusely tender over her shoulder tops and upper arms. And we know already that she does clerical work. So you use more than one consultation. You may do it over a couple of consultations and find out that she's been under a lot of pressure at work and that the company's changing. And she actually has to sit in a stationary workstation for a lot of time, and she often doesn't even get up and have a break. So all of these factors need to be addressed. She actually had a bad experience with hands-on therapy, and she's been very tired. So other things are sort of happening at home. Not too bad, but they're certainly being impacted. She's given up her social things. So these are all the sort of factors that can lead to this downward spiral, but they're also things that can be addressed in a good sort of rehabilitative approach. So the thing you would do is you actually reassure her about your findings, and you might actually develop some scripts. You know, you've talked about it and she expresses some interest, so you say, I'm pleased you're ready to try some things. And in this case, we make a diagnosis of fibromyalgia, and we start to use the language. We know that the nervous systems are cranky and oversensitive, and we work together to calm them down. Then you start to have this open discussion, develop some goals with her and stepwise goals, and you reward progress, and you actually look at relaxation and work breaks and find out what she would like to do. Don't prescribe something that a person hates. You might do the SMART exercise that we talked about before, the sustainable goals, measurable, time contingent. That was the example that I gave before. So fitting in at the right time of day, trying to avoid pain flares. So Beth actually decides that she'd like to do a daily walk, and she starts off with a baseline. She wants to walk 30 minutes a day, but she starts with 10 minutes. But she walks 20 minutes on the first day and she gets too much pain, so she's gone too far. So the next day she works for 14 minutes with some increase in pain, but only for 20 minutes. So, and then she decides to start at 12 minutes twice a day. And so she starts that, and then she does the 10% increase in time every week. And within a few weeks, she's walking 30 minutes a day, 2 times 15 minutes. So that's progress, and that's actually broken it all down exactly the way we want it to. So, in conclusion, I've gone through some understanding of concepts for self-management of chronic pain in the primary setting. I've highlighted the transition, beware of transition from acute to chronic pain and intervene risks. Use a biopsychosocial approach. Don't be afraid to add these things into your normal management. Be aware of the limitations of medications, particularly opioids. Use some practical resources for management for yourself, for education, or for your patient. And think about when you would refer to pain clinic, because often that's a very useful thing for people who aren't getting enough of the treatment they want in the way that they need. So,
Thanks very much, Carolyn. That was such a comprehensive presentation on just what is such an important topic, and I'm sure the audience listening has found, you know, you've covered so many aspects. It's been fantastic. I'd encourage people to type in questions if you have questions at this point in time. We have one question that has come up in relation to, particularly maybe for allied health staff. I'd say this person has an allied health background, with regards to a patient that would come to them and may have already been exposed to negative language with a GP or a radiologist saying, you know, oh, you know, your joints are worn out, it's the worst I've ever seen, lots of arthritis. You know, what would you advise about how do you go about addressing, if you were a health practitioner, that sort of already negative perceptions that might be in place?
Well, I guess it's a lot of work to undo these things, and obviously we want more people to be wiser about it. But I think you probably need to go through with people and try and say, you know, is it necessarily the case that the X-rays are indicating the severity of the condition? And you know, I gave you that Brinkinji slide back there, but actually sort of going through them and saying that unfortunately that the X-ray findings don't always relate to the pain, and that many people, even with these changes, who can undertake self-management. It doesn't need surgery. It's a lot of work to unpick it. I think you just have to sit down and try and have that discussion. And you have to adapt it towards the patient. Obviously, you know, simpler messages are better. Sometimes you just have to be like the scratched record, and eventually it gets through. Making sure that if you're managing them in a team of people that you're all giving a consistent message is very helpful. You know, if you know that you're a doctor and the physio and maybe a psychologist and you're all giving a similar message, then that usually helps a lot. Protecting people from unnecessary investigations or not referring them for surgery when it's indicated is helpful as well. So I think I just see someone who's got a thing about the toolbox, and I think that's a good idea. It's often a matter of finding which treatment and which way is going to make sense for a patient individually. You've got a toolkit, but some people will need one part more than another. But being prepared to put yourself out there and challenge their beliefs and reassure them and take them on that journey, that's what it's about.
Carolyn, we have a question about how do you see pain management working in the community setting. I presume that means the Victorian community health settings and so on. Yeah. I would think it would not be much different to what would be more in general primary health, would you think? Or
yes, I think so, but it's a matter of finding the right set of people. You know, some of the community health centres have some very good programs for activating with people who are very well aware. It might be that you have your own little local team of people that seem to work better with this. Or, you know, we've been working hard to try and get better access to the public system. Like in my own unit, we've got a 2-month waiting list, which is pretty good at the moment, and we're still activating. You know, you need to use those resources as well. But however you do it, try and find the right people. I saw someone flying past there with an exercise physiologist who knows about graduated exercise is good. A physio who doesn't just do hands-on passive treatment, but actually prescribes exercise and has that sort of philosophy. And some physios are trained in CBT. It's really a matter of finding out in your community area what's available and what will be on offer.
And Carolyn, another question, there's someone asking about which sort of practitioners is it ideal to have within a multidisciplinary team for a holistic approach? I suppose it might depend on the specific needs of the patient before you.
Yes, it does. It depends. And I mean, but typically you would have somebody, you know, occupational therapy can be very useful for some patients as well because they're very practical about function. Physiotherapy for reactivating and educating. Psychology to address some of the related values. Often the psychologists do a lot of pain education. A doctor who's understanding about chronic pain and not just wanting to use medication. All of these things, it's really a matter of finding your own resources. I know some country people. I've got a country patient who's actually got a really good exercise physiologist and no physio, and that is good. It's really a matter of the skill as much as the specific qualification. And I just also thought people with pain from different cultures is another question that's there. And to be honest, this is a very challenging thing because you need to find culturally appropriate approaches, and that can be much, you need to modify the approach. Sometimes we've been able to access some therapists who speak in other languages, but also not just the languages of culture, the psychology, which can be helpful, and need to be aware of those particular cultures. There are some stoical cultures with us as well to really tune in. And yeah, there's some good comments here about sick role and cultural things. So I guess there's some societies seem to reward sickness with a lot of over-solicitous care, and that can be a trap of chronic pain. It's not ideal for people to be in an over-solicitous situation where they lose their roles and take to being an infant. It's partly, I guess, a big education challenge for us.
And I suppose issues for people in more remote areas also present a bit of a challenge, Carolyn, with regards to sort of maybe fewer sort of resources in health services in rural and remote areas, of course.
Yes, and I think this is where some of the things that I've given you online would be quite useful because the patients could access them, hopefully, if they've got adequate NBN or something to access some of these online programs. And again, use whatever you have. And I think the other thing is we really probably need to develop more telemedicine services, because some of it can be done remotely. There are some services around there where people do some telemedicine. And that's something we need to use more, particularly in Victoria. I know it's better established in remote clinics. You've really got to just find out what to optimise it and decide when it's worthwhile. Sometimes patients might be worth travelling a bit further to get at least a thorough assessment, which might help with the treatment plan, even if the treatment's delivered in the community. We do that quite a lot in our clinic. We'll see someone once off and do the full team assessment, physio, psychology, OT, medicine, psychiatry if necessary, and then we'll give a kind of recommendation that this kind of direction of approach would be good, and that can be quite helpful without them having to come down all the time.
And also just actually one, you've sort of, I guess, and also just actually one, you've sort of, I guess, touched on it tonight, but the issue of patient expectations placed a great emphasis this evening on patient education, which is obviously vital. How much do you think sort of health practitioner behaviour is driven by patients who come in and really just expect the x-rays, the medication and so on? And again, what approach would you suggest health practitioners take in those instances?
Well, I think sometimes we have to slow that expectation down. I mean, the little motto things like back pain is, surgery is not good for plain back pain. It's reserved for people with neurological compromise. Just little sort of things like that, that people have wrong perceptions about. You've just got to keep working away at it and try and change some of those perceptions. But we all know that there are patients who won't be reassured until they have a radiology and x-ray. But I wouldn't rush in if you don't have to. And if you do it, make sure it's a considered thing, because some people feel that you're not taking them seriously if you don't do the imaging. Maybe if you do it and if you have to, and then you say, look, I don't think it's going to change the management, you do the x-ray, but you can prepare them with this thing like the false positives that don't show necessarily what's going on. But at the same time, hopefully, if you're getting in there early enough, you might be starting to show them already that some of these other conservative treatments are going to work for them as well. So you've just got to work away at it. We've got to educate more people so we've got more messages.
And I guess that's why we do these webinars, to educate health professionals, because it's also, as we know, just even practitioners need sort of assistance and knowledge with regards to how to manage what are often quite sort of difficult cases, I guess.
That's right, and I think one of it comes back to even our basic education. There's not enough pain education in our health professional training, and people who maybe specialise don't get exposed much to community health very well, and I think that's really a big challenge, because really we can deliver this service much more effectively and community-based, much more accessible, but you've got to have some skill set or some tolerance. And there are courses that health professionals can do. There's one at the University of Sydney which can help them if they really want to get a lot of knowledge, or maybe just doing little courses like this and developing some little scripts of how you will address those things.
I've got a couple of messages coming through, Carolyn, just saying thank you very much for this evening, and I'd also like to sentiments. Thank you. It was an excellent presentation, so much information, so hopefully people found it beneficial. So thanks very much, Carolyn, for the work you've put into this evening's presentation and the preparation required beforehand. So I'd also like to thank everyone for joining us this evening. And could I also ask that you take a moment to complete the exit survey, and also could I ask you to again have a look at the list of webinars for our 2017 series, which should also be coming up on your screen at this time. And so, Carolyn, thank you and good night, and to everyone out there watching, thank you and thanks for joining us, and all the best towards the end of the year. Thanks very much.